Good evening. This follow-up to the previous presentations on IV fluid, which started off as trying to solve a single MCQ that was given in your NEET recall. I'd made a series of presentations on colloids, on crystalloids, on the different types of crystalloids, the edge of one crystalloid that has over the other, etc. Finally, we have come down to the debate, which is better, colloid or crystalloid. It is an ongoing debate. So what is most appropriate for volume resuscitation? We are not talking about how you correct hyponatremia, how you correct hypoalbuminemia, but we are going to talk about volume correction. Each type of fluid will have its own loyalists who will defend the merits of the chosen fluid. So as a student, where do you stand? We'll come to it. So there is a description of the issues involved in this debate and a suggested compromise is given. Now this compromise is a compromise in standard textbooks. It is not the compromise that I follow in my day-to-day working situations. So coming to why crystalloids got importance in volume resuscitation. In the 1960s, they realized that shock is associated with an interstitial fluid deficit because the fluid shifted into the plasma compartment. Now, animal models told that hemorrhagic shock, when replaced only with blood, have a bad outcome. And when ringer lactate was given along with it, they had a good outcome. So they realized that giving ringer lactate was a critical factor, and that is why crystalloids shot up to fame. And between ringer lactate and sodium chloride, ringer lactate is better. One, because the sodium and chloride content are far less than the plasma sodium and chloride. And not only that, there is far less acidosis with ringer lactate, because the lactate in the ringer gets converted to carbonate in a good functioning liver. Now, what happened to recent concerns? The recent concerns are not just looking at the volume loss or at the correction of the volume loss or exactly how the volume which got corrected is going to improve the physiology. No, they have gone behind and started looking at the cardiac output and systemic O2 delivery, because we have systems in place to correct these or to look into these issues. So colloids had proven superior to crystalloid fluids as far as cardiac output and systemic O2 delivery was concerned, apart from replacing the fluid in the plasma compartment. But despite all this superiority, crystalloids remain the first treatment of choice. Why? Because the colloids, they have not shown proven survival benefit. And number two, the main issue is the cost factor. The cost difference between a crystalloid and a colloid for ml to ml is 10 times more. That you have to keep in mind. So whenever something is gaining practical applications, getting into the guidelines, people will also factor in the hospital economics, the health economics before they put it into the guideline. So, and one more thing, crystalloid solutions, relatively large volumes, you know that 75% will leave the intravascular compartment. So you have to give 3 times more. If I give 100 ml of colloid to make up the deficit, I need to give 300 ml of crystalloid to make up the deficit. Now, because of this, crystalloids which leak into the interstitial space, they will go and cause edema, and they will increase mortality and morbidity in the critically ill patients. So how do we handle this? There are differences of opinion and an ongoing debate about colloids versus crystalloids or crystalloids versus colloids. So how do you know whether one fluid is enough to address all causes of hypovolemia in all type of patients? So actually this is going to be unreasonable. There will be no single resuscitation fluid which will perform optimally in all these conditions. So when you have a patient with hypovolemia, decide which compartment has got an issue, whether it's the vascular compartment, whether it's the interstitial compartment, or whether it is the cellular compartment. or whether it's a combination of all three or two of them. Once you know, you will be able to handle the issue. So once you decide, like in an accident, in blood loss, I know it's the intravascular compartment that has a severe issue. Now, if there is dehydration because of fluid loss, either diarrhea or vomiting, or in heat stroke when you have excessive sweating, you know that this compartment, interstitial compartment, is the main problem there. So once you decide, you can decide on the appropriate fluid. So coming to hypovolemia, you have decided it's due to acute blood loss. One, because of the history, because of the presentation. You notice acute blood loss, like say hematemesis, or patient with trauma with fractured long bones, or intra-abdominal injury, intrathoracic injury. Life-threatening loss. Intravascular volume is depleted rapidly. There is no time. Somebody can lose 2 liters of blood in 2 seconds. What will you do? You can bring in 5% albumin, but it is not practically possible, because one is the main thing is the cost factor, even in developed countries. Fine. So in practice, you start off with crystalloids as they are cheaper. So you see the ideal and you see the practicality. So you start off with crystalloids because crystalloids will be here for at least 2 hours. Then you follow them up with colloid. This is the idea. Started off with the cheaper alternative. Now, not that all shock patients will need an albumin. They may get corrected with your crystalloids itself. That is the rationale. Now, what if there is fluid loss due to dehydration? The dehydration due to diarrhea or excessive sweating is in the interstitial compartment. Now, for that, you know, you can give your crystalloids, because you know 75% will anyway go off into the interstitial space without any active intervention from your side, and it will take care of the interstitial space. So you give, and in the crystalloids, obviously you will give bringalactate. How about hypovolemia due to hypoalbuminemia? What happens when this big colloids are missing in the bloodstream? Albumin is a large colloid naturally. When it is missing in the big stream, in the bloodstream, the colloid osmotic pressure will be low. So naturally it will push out fluid into the compartments, into the interstitial space. And patient will be having very low plasma volume. Naturally, perfusion pressures will also be less. How do you handle them? Naturally, you replace with colloids. And that is, and the exact colloid will be 25% albumin. Now, for argument's sake, you can say, why don't I give hetastarch and dextran, which are also colloids? They will have the same action of albumin. No. Why? Albumin has the 25% albumin has the highest oncotic pressure. And number two, albumin has a whole lot of other functions, which hetastarch and dextran will not have, because albumin has some immune modulation effects. It will carry drugs, it will carry metabolites. Those things cannot be outsourced to the other colloids, which is your dextran and your hetastarch. So, tailoring the type of resuscitation fluid to the specific cause and the severity is a more recent approach than using the same type of fluid. So your debate ends. What do you do now? He had told selecting the appropriate fluid is, how do you select the appropriate fluid? What is the cause and severity of hypovolemia in this patient? I had given you an example of trauma, of dehydration due to diarrhea, and a hypoalbuminemia. So you ask these questions. Now, what you will do? You will follow standard guidelines. You are safe. You will follow standard guidelines. Like in your ATLS for blood loss trauma, initially you will give 1 liter of any isotonic fluid. 30 years ago, they used to insist bringalactate, not normal saline. But now they have said any isotonic fluid. Correction of dehydration, diarrhea in children, you will correct with bringalactate according to the body weight. This is the standard treatment by the Indian Association of Pediatrics. So when you have a doubt, best is to follow standard guidelines. I've just given you two examples. One is in trauma and one is in dehydration. So after all these presentations on IV fluids in general, on normal saline, on ringer lactate, on lesser reused crystalloids, on colloids, now we have pitched colloids against crystalloids, and I've told you the exact scenarios where you will use what or in what sequence. You may be giving crystalloid and following up with a colloid. So as I told you, normal saline is not normal either chemically, because we have told you 58 grams should be there to call it chemically normal, but it has only 9 grams. And physiologically also it is not normal. It results in metabolic acidosis. So instead of calling normal saline, you would call it isotonic saline. Now, these problems do not happen in Ringer's lactate or Ringer's acetate solution. Acidosis in normal saline is taken off by the lactate in Ringer's. Those liver cell failure patients who cannot metabolize lactate to bicarbonate can be given Ringer's acetate, because this acetate needs only a muscle to clear it. Now, you know, isotonic crystalline solutions will be expanding the interstitial compartment. They will expand this compartment and then go on to expand that. Colloids naturally will be superior to other crystalloids. As I told you, they are larger molecules, they will stay here. Hypertonic colloid fluids are associated with an increased risk of renal injury in patients with acute life-threatening conditions. This you must keep in mind. So the colloid crystalloid debate is misguided because there is no single resuscitation fluid that is optimal for all hypovolemia. So I told somebody in hemorrhagic shock, you will give crystalloid followed up with colloid. Somebody with dehydration due to diarrhea, you will give a crystalloid, which is renal lactate. Somebody with hypovolemia, you want to correct intravascular loss, you will correct it with albumin straight away. Thank you all very much, and I hope I brought some clarity. Thank you for being there with me. This is applied physiology. This is not something clinical to show you images and keep you interested, but you need to know these things. I've tried to make it as simple as possible, and I've only handled the core concepts. You want to know more about this for your personal interest, I can recommend one book which is called Paul Marino's ICU textbook. It's an excellent textbook. I'll try to upload it into the Telegram channel, and whoever's interested can download it. It's a very simple book. They will talk, the cellular level will be talked so easily that even a first year student will understand the clinical implications. So again, thank you. Please do subscribe to my channel, raise your doubts in my channel, and please do follow my Telegram